So we've settled, we've assembled here to discuss one of the most common problems that we encounter in our practices, whether we are specialists or whether we are general orthopedic surgeons, and that's a rotator cuff tear. We get a lot of questions whenever this topic comes up as to how you go about approaching this subject. So therefore, it's appropriately titled as whether you rehab them, when do you decide, if you have to decide for repair, how do you decide, how do you repair, and when do you go ahead with a replacement, like a reverse shoulder replacement. So what are the learning objectives of this session? By the end of the session, the attendees should clearly understand the different case scenarios that I am going to be presenting. There are about 7 different case scenarios. So I hope the panelists will guide us quickly through the different case scenarios so that we can cover maximum. And by the end of the session, we should know how these cases present, how to examine them, what are the most appropriate investigations, when do we conserve, how do we conserve, when do we operate, how do we operate, and which operation for whom. So as you can see, we have got the elitist panel here. We've got shoulder specialists. We've got a very good musculoskeletal radiologist. None of them require any introduction. So we'll go ahead straight on with the case scenario. So that's a typical rotator cuff tear. That's what we are trying to understand today. So the first case, it's a 65-year-old gentleman with pain in the right shoulder of insidious onset for about 3 months. He has not had any significant trauma. His pain is worsening and his sleep is getting disturbed. There are no relevant comorbidities. So this is a typical case scenario. What is of significance here is there is no trauma. What is of significance here is of insidious onset. We won't spend much time on this slide. We'll directly go to the findings on the examination. So his passive ranges, there are 3 important ranges that we examine: the full forward flexion, the external rotation, and the internal rotation. All are nearly full, only terminal movements are a bit painful. So this is his examination finding. That's his forward flexion. That's his external rotation. So with this understanding, let's start with Dipit. So we have a lot of people who are at a general orthopedic level or at a basic level. What are the further examinations that you would like to perform on this particular patient?
So yeah, thanks Nagraj. So what I'll do next is we'll be examining for supraspinatus, infra and subscapularis.
Right.
3 muscles basic testing. Because where is the pain located first of all? If it is in the anterior shoulder, posterior shoulder.
Yes.
If it is giving a typical picture like a cuff tear pain, next step would be to clinically examine the patient and see which muscle testing is being positive.
So we'll take that as the first take-home message. We are now going to go, once we know about the ranges, we are going to go ahead with the muscle testing, like Dipit said, for the supraspinatus, the infraspinatus, and the subscapularis. So Dipit, can you, before I go through this video, you would agree that this is the testing for the supraspinatus?
Yes.
And I have demonstrated 2 tests here. One is the full can test and one is the empty can test. Do you feel this is still relevant, and has this test been performed properly? Can you guide how do you go about this examination?
What I do is I just place the hand like this. This is the classical way, I agree, empty can like this, but it makes the patient more painful. If you are going to get a test, I just place the hand like this. I check the power of the muscle. So against resistance, if he can hold or not, if he's painful or not. But yes, so power is more important is what I'll be testing.
So I leave it to all the seniors now. Anybody would like to add any point here in terms of empty can versus full can? Anybody has anything to say? So with respect to the empty can test, it isolates the supraspinatus because it's in the line of pull of the supraspinatus. So if it is weak, as Dipit said, we understand that the cuff is not functioning properly. That's all we understand. We don't know whether it's actually toned. So we'll go through this video again. So you can see this gentleman. When you do the empty can, it's actually weaker as compared to the full can. So that isolates the supraspinatus. Coming to the infraspinatus tests, so you would keep the hand as resistance and ask the patient to push aside, and that will give us the strength testing. So as you see in this particular patient, it is weak. In the other case scenario, you will see that the patient is unable to even extend even a bit. So that's a complete loss of external rotation. So Dipit, you would agree that on the right hand side is a situation where there is probably a complete rotator cuff tear, and on the right hand side we need to further evaluate what is the status of the infraspinatus.
Yeah, so there's no active external rotation on that side.
Correct. Thank you, Dipit, for that. So now another situation where even if it is worse, where there is what is called as a lag sign. When you take passively the arm into external rotation, ask the patient to hold it and it drops down. So this is what we call as a lag sign. So what does it tell you, Dipit? When there is a lag sign, what does it tell you?
So basically it tells me that the infraspinatus is not working.
Right. What about the other external rotators? Any clue you could point out towards the other important external rotators?
Yes, no, so this of course tells me the infraspinatus. You can even test for teres minor.
Right. So we will go to that, Dipit, now. So that's the teres minor. We would test it in abduction, and that would isolate the teres minor. In abduction, we would ask the patient to external rotate like so. So she's able to maintain her abduction and she's able to actively external rotate, which tells me that her teres minor is intact, and all of us would agree that usually even in massive rotator cuff tears, teres minor is probably the one muscle that always remains intact. It is very rare for the teres minor to go away, and when it does, you have a hornblower sign. So meaning the patient cannot external rotate the arm without abduction at the elbow. So that's a classic hornblower sign where obviously the lag sign is there. However, the hornblower sign tells us that the infra and the teres minor are completely torn. So what I've tried to do is take home messages as we go along the slide so that the audience can understand the testing. Coming to special tests. So do you rely on these a lot before we go ahead how to do it?
Once I have confirmed or maybe clinically judged that there is a cuff tear, I wouldn't do anything because it's not giving me any additional information.
Right. Dr. Desai, do you rely on these impingement tests, that is the Neves test and the Hawkins test?
Yeah, it adds to my knowledge a little more.
Yes, sir.
That the cuff is source of his symptoms.
Yes. Also, if we are understanding how this test functions, this is the position of narrowing the coracoacromial arch. So when you put the arm into forward flexion internal rotation, it narrows the coracoacromial arch, it irritates the cuff, and that is what causes pain to the patient, especially when you do the Hawkins maneuver. In a forward flex position, when you do an internal rotation, it again hurts the patient, which tells you that the cuff is getting irritated when you narrow the coracoacromial arch. So I think we have completed the tests well. The panelists have helped me to understand how to evaluate a rotator cuff. Before we go ahead for the further evaluation, so that's another case scenario. A patient who's got a very weak shoulder. Literally appears as if the patient has a rotator cuff tear, but we'll come to this later. Another patient, again impingement sign and a severe Hawkins test positive. So these are the tests that we do. Before we complete the examination, we do examine for the AC joint. Everybody relies heavily on the AC joint test. Dr. Narvekar?
Yeah, it's part of the examination. But if you allow me to divert a little.
Yes, sir.
Maybe before he would have put this shirt on, I would have examined him from behind.
Yes.
I would have seen how he raises his shoulder, especially his internal rotation when he is getting impinged and painful, what is happening to his scapula.
Absolutely.
Whether the scapula is moving in the right direction, whether the medial border of the scapula is prominent, and therefore the internal rotation is giving rise to an impingement pain.
Absolutely.
That tells me what is happening.
Absolutely. So shoulder examination always starts from behind. For purposes of keeping this presentation lucid, I have not included that, but it always starts from behind. We expose the shoulder from behind, and almost always we see that the scapula is weak. That's a rule. Dr. Narvekar would agree. By the time patients present to us, it's always weak, and unless the scapula is stabilized, the patient's pain is not going to go away. AC joint tests are important because we need to differentiate whether the pain is purely coming from the impingement in the subacromial space or in the front of the shoulder also. Like you see here, he says that the pain is pointing more towards the supraspinatus point. Coming to imaging, Dr. Darshana, what is the classic imaging that you would advise for this sort of a patient who has pain in his shoulder of insidious onset and these findings? What is the first investigation of choice?
I think we can directly go for an MRI.
Okay. Anybody else would like to, Dr. Garude, would you feel going for an MRI directly or?
So I would speak to the patient and see how disabled he is by this. Since 3 months, he hasn't had any treatment and his range of movement is full, he's otherwise okay. is it something that you're really immediately contemplating a surgical approach?
Correct.
If not, then perhaps just a simple sonography to try and assess what the situation is good enough for me.
Anything else, sir? Anybody else would like to get anything else done?
I'll get an investigation done if I'm going to change my management or it's going to add to my management.
Okay.
I've got full range of movement, right?
Okay.
I'll get an X-ray.
Right.
Plain X-ray first.
Yes. Yes. So I think it's very important, especially for the beginners, that you need to get a plain X-ray done, and we all need to understand what is a proper X-ray, how to take it, etc. So few slides for that reason. Dr. Darshana, we will come to the MRI part, but we will need your inputs on the X-ray also. So this is an AP view, which all of us would agree typically is what our technicians take. Are you guys happy with this X-ray?
So this is not a true AP view
Right.
of the glenohumeral joint. You can
Right.
see that the glenoid overlaps with part of the humeral head. And what we need to obtain actually is a true AP view of the glenohumeral joint, what is called the Grashey's view.
Correct.
In which situation the patient is turned about 30 degrees with the affected shoulder touching the cassette by about 30 degrees so that the anterior and the posterior glenoid rim exactly overlap.
So that's the
Correct.
video showing what Darshana is explaining. You need to turn the patient 30 degrees such that the scapula is now parallel to the cassette, such that you get this Grashey view where you see the entire glenohumeral joint and its true profile. And this is absolutely essential because you get a tremendous amount of information here. What is it? The first thing that you would get? You would understand if there is a superior migration of the humeral head. You would understand if there is a reduction in the acromio-humeral distance, correct? What would you add a few points on this, Dr. Darshana? What has happened here?
So are these the I don't think this is the radiograph of that patient. Is it the radiograph of
No. So as I said, so we are going along with the patient. We are discussing a classic scenario so that the audience gets a take-home message, how to investigate any patient with this presentation.
Right. So on the radiograph on your left, we can see, as Nagraj said, that there is some superior migration of the humeral head, and there is a bit of acetabolization of the acromial process and an acromial spur. The acromio-humeral distance is reduced. It should normally be above 6 millimeters. So maybe very early rotator arthropathy.
Right. So what we are seeing here is that there is a superior migration. It just tells us that the rotator cuff is not doing its job properly. What is the function of the rotator cuff? To push the humeral head down. It could be swollen, what we call as tendinosis. It could be partially torn, which we'll discuss in detail, or it could be completely torn. It doesn't tell us anything but the fact that the cuff is insufficient. And that's the Gothic arch. The corollary is the Shenton's line of the hip. And that is what you need to see in a normal shoulder. If this Gothic arch is disrupted, as you saw in the previous X-ray, it tells us the cuff is not functioning properly. We'll just finish how we get other views. These are absolutely important. Rotator cuff tears can sometimes present with dislocations of the shoulder. You can have combination of Bankarts with rotator cuff tears, bony Bankarts with rotator cuff tears, wherein you should be able to know how to get an axillary lateral. This is difficult in a traumatic scenario, and therefore you should know how to do a Welpow axillary lateral view also, which will give you adequate information as to the position of the humeral head, the profile of the glenoid, if there's any break in the continuity of the glenoid, any arthritic changes. So lots of information, and most importantly, to finish the entire X-ray series is the scapular Y view or the outlet view, which tells you the acromial profile. So that's how you get it done. You make sure that the spine of the scapula is parallel to the X-ray projection. The arm is in neutral rotation, and you turn the patient to achieve that. If you do this, you're going to get a nice Y view. So that's a Y view. Before we proceed with the patient, Dr. Desai, is this something which is very relevant for you in your practice today? We know Liu-Bigliani's classification. So type 1, type 2, type 3. Is it something very relevant for you in your practice today, this Y view?
The relevance of acromial shape contributing to cuff disease is now much less.
Agree.
But I still want to know if there is a mechanical structure like a spur which is irritating the cuff, and that could be an after effect of long-standing cuff disease.
Correct.
So I do want to know, though the etiology and it contributing to the disease is now less and less,
Correct.
more or less disproved. Yeah.
Correct. So what Dr. Desai is saying, that we agree, we do not feel that the pathology leads to impingement more often. It rarely can happen. I'm going to show you some slides for the same. But more often it's a secondary adaptive change. So chronic impingement can actually cause a traction on the CA ligament, which can actually calcify, which can actually ossify and cause this sort of a hooked appearance. However, for purpose of knowledge, you should know that there are 3 types as per Bigliani: the flat type, the curved type, and the hooked type, which is rare. So, coming to this X-ray and this pointer, Dr. Darshana, is this something of relevance?
Looks like maybe a small acromial spur or a
Yes. So again, there is a lot of impingement. There is a what is called as a sourcial sign, which should again point out that this impingement has been there for a while. Like Dr. Narvekar said, you need to examine the patient in toto. Scapular is weak, impingement is there for a while. On X-ray, you see the sourcial sign. You know you need to counsel the patient that it's going to take time. Whatever you do, it's going to take time for the pathology to get reversed. And this is a rare presentation, keeled acromion. So, Dr. Desai, is this something that you have seen, and is there a reason for worry in these sort of cases, a keeled acromion?
Yes, because they are nasty in terms of causing more and more attrition of the cuff. And if you end up operating on these at some stage, I might want to remove that keeled acromion.
Dr. Narvekar, I haven't seen this keeled acromion. How about you with your immense experience? Have you seen this and prophylactically advise surgery for these patients when they have had maybe a partial bursal surface tear, because you know that these are likely to go for a complete tear?
It all depends upon the symptomatology at that point
Yes.
of that particular patient. What his symptoms are, because what you see on the radiology may not actually project on what the patient has. But if I decide to operate, like what Sanjay said, we definitely look at the keel, and which otherwise you probably would neglect to see the acromion at this point.
Right.
But once you have this type of a picture, yes, if you
Right.
decide to operate.
Right. So, the take-home message is this is a condition which you need to be careful, because they are likely to progress, and this probably could be an indication for an isolated subacromial decompression acromioplasty. Otherwise, if you are posting a case for a subacromial decompression in today's day and age, it is not appropriate. Coming to a critical shoulder angle. So, a lot of discussion has happened in our fraternity, Dr. Darshana, about the critical shoulder angle and its importance, because we've been looking at the front of the acromion and not on the lateral border of the acromion. And any input from your side about this?
Yeah, so in the past decade or so, the critical shoulder angle has acquired a lot of importance in the diagnosis of rotator arthropathy. It defines the relation of the glenoid rim to the lateral extent of the acromion. So it's drawn by an angle that one line joins the superior and inferior glenoid rim, and the other one from the inferior glenoid rim up to the lateral border of the acromion. So it takes into account both the lateralization of the acromion as well as the superior tilt of the glenoid in determining the biomechanics. The angles more than 35 degrees indicate that the patient is very likely to have a rotator cuff tear. And the higher the angle, for example, more than 38 degrees even indicates that there is likelihood of, or there is an increased incidence of re-tear after surgery, whereas smaller angles, for example, less than 30 degrees indicate that the patient is likely to have osteoarthritis.
Perfect. Dr. Darshana, thank you for that input. Dr. Modi, in UK, is critical shoulder angle something that you look for in all your patients, especially with the workload of arthroplasty being higher?
Not really.
Okay. So this is a good take-home message. It's something which you can have in your X-ray evaluation. It's very simple, which tells you that an increased angle, the patient is prone for a cuff tear, and you need to be careful when you're doing the surgery also, not just look at the front of the acromion, but also on the lateral aspect. Coming to AC joint quickly, there are dedicated views for the AC joint called as a Zanka view, where you just tilt the X-ray beam cephalad by about 10 degrees and gives you an entire nice profile of the AC joint and tells us if there are any osteophytes, etc., which needs to be taken care. Obviously, all this will be covered on the MRI, and we'll quickly come to that. So coming back to a patient who has impingement, his X-ray is showing social sign, the Gothic arch is maintained. So we would obviously go for an MRI. I held back Dr. Darshana for a while now. So Dr. Darshana, this is a typical MRI coronal proton density fat suppressed image. Is that the first sequence that you would see?
Yeah, perfect, yes.
So you would start from the front of the shoulder and progress?
And, yes, and scroll backwards.
Yes.
This is a coronal in the plane of the supraspinatus.
Yes.
And we see an intact supraspinatus here.
Yes.
There is some joint effusion. The acromioclavicular joint, if I may see it.
So the idea of showing this slide was that this is how you would start your examination with the coronal sequence, and you would go from front to back, evaluating the supra, infra, and the teres minor. You would obviously look at the AC joint, you would look at a lot of other things, but let us restrict ourselves to the cuff today. So this particular gentleman whom we saw with impingement has these sort of findings. So could you tell us something more than what has been given on the heading? That's a bursal surface tear and a type 3 acromion process. Would you agree with the heading?
Yes, it describes it very well. And with MRI, we can measure the width of the tear, the length of the tear, the quality of the tendon, the extent of retraction of the tendon, and all of this would be useful in planning for the surgery as well as prognosticating. So here we can see that the tendon is not substantially retracted, maybe a Pate's classification 1. So 1, 2, and 3 describe increasing extents of tendon retraction, which has a direct bearing on the comfort that the surgeon will have in obtaining a complete repair, as well as decrease in pain and disability after repair. And this is about a grade 2 quality of the tendon, meaning there is some mild degeneration.
We'll come to that. We'll come to that. So she talked about bursal surface tear. She talked about the dimensions. Dr. Garude, do you feel this is a complete tear? I apologize. This is a single image. I agree. But with your experience with this presentation of this patient, do you feel it's a complete tear or it's a high-grade bursal surface tear?
Yeah. So in these people, when you go glenohumeral, one single angiocath you put in, and just even with that, you can almost complete it if
Correct.
it is not already complete. So
Correct.
it is technically almost like a complete tear.
Correct. So this is the scenario we have. We have a middle-aged gentleman who has impingement signs, who's got a near-complete bursal surface tear. There is a type 3 acromion. We have understood what is the importance of it. Now we have to understand how do we manage this. Starting from Dr. Desai, what would be your first line of management for this gentleman?
So I would offer conservative treatment to start with.
Okay.
However, I will counsel the patient that we are making an attempt at conservative treatment, which would mean exercises to stretch the posterior capsule, because often they have posterior capsulitis, strengthen the cuff.
Yes.
I may use a steroid injection if the pain is stopping him from rehab.
Okay.
Often they have secondary capsulitis, so the injection has a role to play if the pain is an issue.
Yes.
And put him on rehab, but I'll counsel him that you have a type of tear and your bony architecture is such that you may need surgical intervention.
Thank you for your input. Dr. Narvekar, would you have a low threshold to operate these? Because like Dr. Garude said, there are a few fibers which are holding on. It's just a matter of putting an angiocath there.
Yeah, with the type of symptoms, with the age of that patient, I think I would probably go ahead in surgery.
Okay.
Two things I would not do conservatively. One thing is I would definitely not strengthen the cuff.
Okay.
And secondly, I'll never give a hydrocot.
Okay.
Because that tells me that when I operate, that cuff is not going to heal.
Okay.
So these two things I would not do. And
So
in my mind, I know I'm going to operate.
Okay. So this is exactly what the audience will now start understanding why there is so much of discussion about rotator cuff. You saw two stalwarts having two opposing views and both are valid. So how do you select what is the right thing for the patient? That is probably the take home message. So before we go for what we did for the patient who has a high grade bursal surface tear, quickly seeing the other findings, he's got some tendinosis and some tear. You would obviously look at the axial images to see if the subscapularis is okay and the biceps is in its groove. And you would look at the muscle quality. Before we go for the management, let us finish off with Dr. Darshana. Could you just shed some light here? Are you happy with these images and the details of the tangent sign, please?
Right. So what is directly related again to the prognosis of the patient is the muscle mass of the residual rotator cuff, as we know. The very simple sign to assess this on a sagittal MRI is the tangent sign. The tangent sign is assessed on a sagittal T1 weighted image where you can see the coracoid process, the body of the scapula and the spine of the scapula in a single image. And here we can see we have to take a line which connects the superior margins of the supraspinatus fossa. And if we see supraspinatus muscle above that line, it is called a negative tangent sign, and it means that the patient has sufficient muscle mass and will do well after surgery. So that's a negative tangent sign, but if there is muscle atrophy below the red line, that means that the patient already has very significant muscle atrophy. As the muscle atrophies, we know that it is replaced by fat, and the classical classification system for assessing the amount of fatty infiltration of the rotator cuff is the Guttalia classification, which goes from 0 through 4, and very quickly I will do you want me to tell the classification or just the principle?
So we'll keep it brief because we want to
Yeah,
cover a
sure.
lot of information. So,
So
what Dr. Darshana is trying to say is in this image, so there is a muscle which is reduced like she said, but there is fat within the muscle, and simply saying grade 3 is fat is equal to muscle, grade 4 fat is more, and grade 3 and grade 4 are bad. So that's what basically it has to say, the Guttalier classification. Quickly, we will summarize the partial cuff tears. We discussed in detail about the bursal surface. We need to understand the intratendinous tears also and the articular surface tears. The approach is very similar. We usually try for the conservative modality except for the high-grade bursal surface tears where there is some discussion still pending. But for the ones which are intratendinous, the ones which are articular surface, we know that there is an impingement-mediated component, and usually you would try for a conservative line of modality initially. So that completes the partial tear. So what I did for the patient, similar type of patient I did was I conserved her. I believe that these can be conserved and you can do what is called as a near sign. So effectively when you put a steroid or a local anesthetic for that matter, Dr. Narvekar is right, giving a steroid has its side effects, but it is not so bad if you give a single shot. We have done quite a few of these cases after a single shot and we don't see any much of an issue. And you need to make sure that you mix a good local anesthetic, and if you do so, you need to understand that the subacromial space is actually in the anterior 1/3. You need to target the anterior 1/3 area. It is not posteriorly. So that is the take-home message here. And if you do this ultrasound guided, then you can be more accurate. And it is especially relevant for the intra-articular injection. For the patients who have stiffness, in addition to pain, impingement, you can add an intra-articular injection of steroid also, which will make sure that the capsulitis component which Dr. Desai mentioned is taken care of. And for the intra-articular injection, an ultrasound guided modality is better because you are 100% sure that the drug has reached in the right space. If there is AC joint changes, you can always do this ultrasound guided or C-arm guided. So that's the rule. Now that's the near sign. So that's the patient who has severe impingement, and immediately after the procedure, she's got complete relief. So she's the lady who's got a partial articular surface tear. This is a gentleman who actually appears as if he's got a complete tear. We remember this video. And we work like a near sign for him, and you see immediately after the injection, he's surprised that a person who's not moved his shoulder for so many months is completely relieved. So this is the classic near sign. So a lot of these cases can actually go for a good conservative modality. Obviously, rehab is the cornerstone. Now, obviously, if there is a failed conservative treatment, then obviously I would go for the repair, and that's the classic scenario wherein there is a high-grade bursal surface tear, few of the articular surface fibers are intact. You might complete it, do an anchor-based repair, or you could do a speed bridge kind of a repair. The idea is to make sure that the impingement is gone and the cuff is repaired back. And these patients, even we see in young patients, they'll end up doing extremely well. So that completes the partial scenario. Before that, the intratendinous tear. This video, thanks to Dr. Narvekar, I don't think he remembers this, but this is his video. This is the sign which we do for the intratendinous tear, which is a ballotment sign. We take a needle and we infiltrate saline. So the intratendinous tear appears, and when we put a shaver, we realize it's actually a complete tear. So the failed conservative line of modality, intratendinous tears, this is how we handle them. We do the regular cuff repair following that. And rarely you would do a partial articular surface tear repair intratendinous manner. This is something that I've not really been a big fan of because you create a high tension kind of a repair, but that's just to complete the entire understanding of how you manage these partial tears. Take home message, have a thorough clinical and radiological evaluation, manage them conservative initially, and the high grade near complete bursal surface tears, however, are usually amenable to repair, but make sure you do it in a low tension manner and release the entire impingement by subacromial decompression. Case scenario 2, a young girl, right shoulder pain, Dr. Desai, sorry, yes.
If I may add, it would be inappropriate to send a message that all bursal side tears mean surgery.
Correct.
That's not true at all.
Correct.
Many can be conserved. It is not a validated statement that one shot of steroid injection means your cuff won't heal. That's not validated. That's not true.
Correct.
I've
So
been
there are
injecting in thousands. Yeah.
correct. So that's the take home message. Both the aspects are there to be understood. You obviously need to look at that particular case scenario, demands of that particular patient, and take a call. Coming to the second case scenario, it's a 25-year-old girl, pain in her right shoulder. She's a badminton player. Again, incidence onset, no history of trauma. Her range of motion as such is normal. Her cuff strength, she's painful and 1+ weakness. Dipit, could you explain what we see in these images?
So one side internal rotation is restricted, which is on the right side. Left side internal rotation is okay.
Right.
50% or more restriction.
Right. So Dipit, as you rightly said, this is an internal rotation examination in abduction. This isolates the posterior capsule, and we would call it as a GIRD, also called as a glenohumeral internal rotation deficit. So what it means is, on the normal side, this is her normal internal rotation in 90-degree abduction, and on her affected side, she can't get it to that internal rotation position. And this is a very common scenario we see in overhead players, in regular people also, which classically tells us all the movements are okay, except this. That means the posterior capsule is tight. The posterior shoulder capsule is tight. And this is the classic triad that we see. Dr. Darshana, could you enlighten us with this triad? So on the coronal images, you see that there is some amount of tendinosis.
Yeah, and maybe some bursal surface fraying.
Yes.
And I think the arrow on the bottom right is pointing towards the labrum.
Correct.
The posterior labrum.
Yes.
And some
Cystic changes in
the humeral head at the infraspinatus insertion.
Correct. So this is a triad which was classically called as an internal impingement. So impingement syndrome, we finished the external part, we are coming to the internal impingement. So when a patient has posterior capsular tightness, the humeral head actually moves up and the cuff gets impinged between the superior glenoid and the greater tuberosity, causing this sort of a scenario. So there is a cyst, there is a posterior supra or an infra tear, and there can be a posterolabral tear. However, the first line of treatment would be to do a rehab program and make sure that the GIRD is corrected with the posterior capsular stretches, and if you do so, the GIRD is corrected. Now, if you have this situation, Dr. Garude, so this patient is having GIRD. Along with that, as you can see, there is a large paralabral cyst with a posterior labral tear. So my question to you is, the patient has internal impingement, the patient has GIRD, the patient has pain because of the cyst also. How would you go about in terms of your management? Would you conserve initially, operate? How would you go about it?
So I'm assuming that there's been no neurological compromise by the cyst just yet, since you've not mentioned it. Initially, it has to start off with rehab. You have to get rid of the tightness, because without that, anyway, trying to do any kind of a repair within, at some point in time, that will fail if your basic tightness has not been addressed.
Correct. Right.
There is some denervation edema in the infraspinatus.
Yes.
You can see it's a bit brighter than the teres minor, so I think there should be
I'll come to the clinical picture. I'll give you more clinical picture. So, Dr. Modi. So this is a situation where there is a selective wasting of his infraspinatus. So, Dr. Modi, any inputs here? Is the same patient, yes. The idea is to give a take-home message to the audience. This is not a shoulder.
The cyst that you showed me, was that from that girl, or that is a different?
So the girl scenario, the girl case is a case of GIRD. That is what I wanted to show.
So
the next
that is
question.
over.
Yes, that is over.
Oh, okay, sorry. Okay, fair enough.
She's fine. She's happy. She's gone back to badminton. My second scenario is of a person who has got GIRD, like I told Dr. Garude, who has got a cyst on the MRI, and this finding. What would be the pointers for this case?
Yeah, so I mean, actually, I answered thinking that MRI belonged to that.
I understand. I've created in such a way that there are a lot of messages.
So if there is a significant amount of infraspinatus wasting, you have to look at the suprascapular nerve, right?
Correct.
And if that is compressed, then there is an indication for decompressing that cyst and repairing the rent in the labrum. But if there is an internal, I don't know if there is an internal rotation deficit in this patient or not.
That was the question.
If
there is internal rotation
then
deficit.
You do need to address that as well.
Yes.
So I think there is always time to address this a little bit pre-operatively.
Correct.
No patient really comes to the clinic today and is on the table tomorrow.
Correct.
There's always a few weeks in between. You can start stretching this out.
Correct. So that's the take-home message. So when these patients come to you, they might have a neurological component. They might be weak. They might have the selective weakness of the descending branch of the suprascapular nerve. But if they have severe GIRD, you need to work on their posterior capsular stretches, make sure that that is gone, because post-op otherwise they can have refractory stiffness, because what we are going to do for them is, so this is the patient who's got severe weakness with the paralabral cyst. So what we are going to do for them is going to decompress the cyst. You see this gelatinous material, and usually you will land up repairing this. So imagine if there is a tight capsule and you land up repairing these, they can be a real problem case post-op. So that's the take-home message from this particular case. So that's his recovery. It takes time for these patients to recover. You need to counsel them, and they recover completely in terms of their strength. So two different case scenarios, one external impingement, one internal impingement with a cyst which is significant, internal impingement with a cyst which is not significant, managed conservatively. So that's the